Hello, everyone. I'm Kelly Lendvoy from Arthritis Consumer Experts, and welcome you to another special episode of hashtag CR Arthritis as part of our work at the annual scientific meeting of the Canadian Rheumatology Association. One of the concurrent programs to the scientific meeting is a session called CRA RheumReview, and that provides a clinical update in a full day format that allows Canadian rheumatologists to update themselves on some of the hottest topics in arthritis research. And today we have the pleasure of one of the presenters at CRA RheumReview this year, and that's Dr. Victoria Werth. Dr. Werth, welcome.
Hello, it's great to be here.
Dr. Werth's professor of dermatology and medicine at the University of Pennsylvania School of Medicine and chief of the Division of Rheumatology, specializes in clinical and translational research in autoimmune diseases. Dr. Werth, your session at RheumReview is titled Approach to Cutaneous Lupus for the Rheumatologist, and it's going to review the clinical findings of cutaneous lupus erythematosus, CLE, the workup of such patients and approaches to treatment. And I wonder, to start off, for patients in our audience who may not be familiar with the term, could you explain what CLE is and how it differs from systemic lupus erythematosus?
Absolutely. Well, I should tell you, I am an internist and dermatologist. And
Mhm.
so I specialize in people who have autoimmune skin conditions, and many of them have systemic disease, but often the skin is sort of the predominant feature for them. And so cutaneous lupus patients tend to sometimes get other features of lupus, such as arthritis. They might get, other features. But again, in particular, there are a number of different types of skin problems that people can get. The most frequent one is, in terms of isolated cutaneous lupus, would be discoid lupus, and that can be very disturbing. It's often in distributed areas. It can be somewhat red and scaly and uncomfortable, and sometimes will resolve with itching or rather with dyspigmentation and even scarring. And so there are different subtypes that go along with lupus, and some are more likely than others to have systemic features. So one of the things that we do with our skin lupus patients, which skin is cutaneous lupus patients, is to follow them sort of very systematically and make sure, for instance, that the kidneys aren't getting involved, and really trying to be very careful with monitoring people over time. So the difference is systemic patients really meet criteria for systemic lupus, whereas cutaneous lupus patients maybe half the time meet those criteria, but the other half of the time they just can have predominantly skin problems.
Now, in your session, you're going to talk about the importance of early diagnosis and testing for comorbidities in patients with CLE. What kind of additional health issues can be associated with CLE, and why is it important for patients to get tested early?
Yeah, so as I already alluded to a little bit, patients with cutaneous lupus can go on to more serious systemic disease, and so that's a comorbidity that they can actually have lupus nephritis over time, and so we have to make sure that they're not getting protein in their urine. The other thing is that, and one of the comorbidities that we really pay attention to is cardiovascular disease, atherosclerotic disease. And we've done some studies in our cohort. We have now about almost, I think, 600 plus patients in our cohort that we've been following over a lot of years. And we've been able to look at what percentage of patients with SLE versus cutaneous lupus get heart disease. And it's equal numbers in both groups. However, the risk factors for the cutaneous lupus patients are really conventional risk factors, which means the cholesterol is too high, blood pressure is not well controlled, the sugar is not well controlled necessarily. And these are all things that can put people at more risk of having heart disease. And so we're going to talk a little bit about the screening that's required to try to prevent that from happening, and the importance of treating, for instance, high cholesterol levels, and potentially even treating more aggressively for people who are more at risk because of their cutaneous lupus or systemic lupus. And so that's an area that we really like to highlight and try to really make people aware of. And so so those are some of the comorbidities we'll be talking about.
Now, from our experience, working and dealing with people living with lupus, treatment can sometimes feel like trial and error. Can you walk us through the treatment options most commonly used for CLE and maybe explain what patients can expect when discussing treatment options with their healthcare providers?
Yeah, that's a great question. Very much the treatment algorithm will depend a little bit on how severe the disease is. So if somebody has really mild disease, we're going to emphasize sunscreens, SPF of 70 or higher, sun avoidance, sun clothing, all things that can trigger both cutaneous lupus and systemic lupus. And if the skin is a problem, but very in a limited way, we might only be using certain topical steroids or topical immunomodulatory agents. And, that can be, for a few people, sufficient. However, many people end up having to go on more systemic medications. And I would say the first level of medication that we might think about are things like hydroxychloroquine or other antimalarials. And these are good because they can help the skin condition, but they can also, in some ways, for people who are more at risk of getting systemic lupus, it can prevent that progression. And so we're really looking to those medications as an early approach, although they can take a while to work and takes probably at least a couple of months for the hydroxychloroquine, if that's going to work to be effective. And then after that, we have now an increasing number of medications that people can think about. And so, for instance, if somebody really has bad disease, it's not responding to antimalarials and other measures that we just talked about, then we might use an immunosuppressive, things like methotrexate or mycophenolate mofetil. It would be one approach. Another approach, which is really quite more new, is more of a biologic approach. And so that would be including things that have effects on B cells, and very often things like belimumab. For certain people with kidney disease, it would be rituximab. And for the skin and more systemic disease, we know that things that have effects on blocking type 1 interferons, like anifrolumab, can be really effective. And what's really neat to be able to talk about this part of the field now is that there are many drugs in development, and many of them are going to work quickly. They're relatively safe, and they need to be tested in patients with cutaneous lupus. Right now, all of the trials have been done more in systemic lupus, but now there's a very much more interest in cutaneous lupus. And I expect in the next 3 to 5 years that the landscape is going to change, and we're going to have many more options to treat people with, again, things that can be more rapid onset and potentially just as safe or safer than what we have now. So it's a very exciting time. And I've been involved with developing a disease severity tool that measures the skin. It's called the CLASI for people who have cutaneous lupus, and it's allowing us to really have a better idea of how effective the medications can be. We know that the impact of having skin disease has a huge effect on quality of life, and we know that when we improve the activity in the skin, the quality of life really can get much better.
Thank you. And for the audience to, as a reminder, some of these tools that you're talking about, we're going to try to provide as many links as possible to resources at the end of this episode. So for people to look for that in terms of getting more information. And when it comes to self-educating or shared decision making, those are sort of two areas that we work here at ASON a lot with our members. And I'm just wondering if you could speak to that shared decision making aspect and having a conversation with with your healthcare provider in the context of patients with cutaneous lupus, maybe how to advocate for themselves in clinical settings. Are there are there specific questions, for example, they should ask their rheumatologist or dermatologist to ensure they receive the best possible care?
Yeah, I mean, I think one of the issues is that the care is a little bit specialized and
Hmm.
changing very rapidly. I also wanted to mention that there's now some drugs that may be more subcutaneous, and one of the ones that's being developed for cutaneous lupus has effects on inflammatory cells in the skin. It's called litifilimab. It was published in New England Journal couple of years ago, and there's a phase 3 trial going on. So one of the things to talk to providers about is if you have a severe case of lupus, to think about, well, where are the centers that are actually investigating this, and how do I get access to some of the newer treatments? And that is one thing. But the kinds of questions in terms of shared decision making, I would say it's really how much a particular skin problem bothers a patient can vary from patient to patient. Some people, the skin might be really fairly severe and it's not really bothering them, and they don't want to take the risk of taking more medications. And that's part of the shared decision making, is finding out what the patient wants, what's bothering them the most, what's going to make the biggest difference in their life. And you need to find a doctor that's willing to talk to you about that and listen to you, because I think that's part of shared decision making. It's really not possible to just say this is your one choice and this is what you're going to do, because we have more than that choice. And especially with the skin, it's going to depend on a particular person, how much things bother them. So that, I think, what I would say in terms of talking to your doctor is to make sure they understand the impact for you, understand what your concerns are about anything else that you're going to be adding, and also willing to discuss with you, maybe not even making decisions at that visit, being willing to wait and have you digest what you're thinking about after you've heard more about things, and then revisiting what you want to do. So these are all approaches that I think can be really helpful to facilitate the discussions that will lead to choosing the right treatments.
That's great insight, Dr. Werth. Thank you so much for that, and thank you for joining us today. We really appreciated you sharing some of the key highlights from your session. Thanks again.
Very much. Good speaking with you. See ya.
And thanks to everyone else in our audience for watching. We hope you can join us again for another episode from hashtag CR Arthritis as we share more science presented from the annual scientific meeting from the Canadian Rheumatologists Association's meeting. Thank you again. Bye bye.